Finals SAQ 78, Non-Obstetric Surgery During Pregnancy. A 28-year-old woman presents for acute appendicectomy. She is 22 weeks pregnant. A. List the risks to the fetus during anesthesia for the mother. These risks include hypoxia and hypercarbia, organ hypoperfusion, neuronal apoptosis, and risk of miscarriage. Failure to adequately manage the maternal airway and ventilation may lead to uterine artery vasoconstriction, hypoxia, hypercarbia, and myocardial depression of the fetus. Organ hypoperfusion. The fetal placental unit is entirely dependent on maternal perfusion pressure. At term, uterine perfusion increases to 10% of cardiac output from a uterine blood flow of 50 to 700 mL per minute. UBF equals UAP minus UVP divided by UVR. Reduced UAP or increased UVP or UVR reduces uterine blood flow, which is not autoregulated unlike blood flow to other organs. Therefore, it is necessary to maintain maternal blood pressure and prevent the effects of aortocaval compression. Hyperventilation of the mother leads to hypocarbia, which may cause uterine artery vasoconstriction, poor perfusion, leftward shift of maternal oxyhemoglobin dissociation curve, and reduced delivery of oxygen. Neuronal apoptosis. As yet unconfirmed or unquantified anesthetic-induced neuronal apoptosis in the developing brain may occur. Risk of miscarriage. This is unquantified. Majority of the risk is likely attributed to the disease process itself, necessitating the surgery, or the surgery itself. B. How can the risk to the fetus be minimized? Defer surgery until after delivery, unless surgery is absolutely necessary. For elective cases, postponing to 6 weeks postpartum is recommended. Multidisciplinary approach. Involve the obstetrician in the assessment of pre- and post-op maternal and fetal well-being. Airway and respiratory. RSI after an acid pre-medication with rapid securing of the airway. Ventilation targeted to normal EtCO2 and oxygen saturations to reduce hypoxia and hypercarbia in the fetus. Extubate awake and sitting up. Cardiovascular. To minimize placental hypoperfusion and reduce delivery of oxygen. Left lateral tilt to reduce aortocaval compression. Maintain euvolemia. Treat hemorrhage and avoid anemia. Maintain maternal blood pressure at normal levels. Tocolytic effects of inhalational agents is advantageous. Adequate analgesia and avoid light anesthesia to avoid increased catecholamines that compromise placental perfusion via vasoconstriction. Regional analgesia with LA agents may be preferential. Simple analgesics such as paracetamol and opioids may be used. NSAIDs should be avoided. Neurological. Shortest duration of anesthesia possible to reduce the exposure of the fetal brain to anesthetic agents. Avoidance of GA through the use of regional or neuraxial technique where possible. Detection and suppression of premature labor. Women should be told to report sensations of uterine contractions so that appropriate tocolytics can be instituted. C. What additional pre- and intraoperative steps would you take to ensure fetal safety if she was 27 weeks pregnant? Discussion with neonatologist preoperatively. The fetus is now viable, and preparations for consequences of premature labor are essential. If an ICU cot is not available, consideration should be given to in utero transfer to a hospital where a cot is available if maternal condition permits. Discussion with obstetricians regarding the need for tocolysis and steroids for fetal lung maturation. Urgency of surgery may not allow time for this to be fully effective. CTG fetal monitoring, pre, intra, and post-op. Plan surgical approach. Ensure liaison between the obstetrician and surgeons regarding the surgical approach, open versus laparoscopic, with consideration of site of laparoscope insertion. Avoid NSAIDs to avoid the risk of premature closure of PDA. Examiner's report, 33% pass rate. Additional information. Anesthetic considerations for non-obstetric surgery during pregnancy. Introduction. 1 to 2% of women require incidental surgery during pregnancy. Understanding the physiological changes of pregnancy enables safe delivery of anesthesia while caring for the mother and fetus. Although various fetal risks such as fetal loss, premature labor, low birth weight and teratogenicity are attributed to surgery during pregnancy, fetal well-being is intimately tied to maternal well-being. Obstetric and neonatal consultations are critical to the patient's care, regardless of type of surgery. Risks must be discussed, including miscarriage, with the patient and documented. Some key anesthesia-relevant timings in obstetrics. First trimester, there is greatest risk of teratogenesis, especially at 2 to 8 weeks. When possible, delay surgery until postnatal period, or alternatively into the second trimester when teratogenic risks to the fetus are reduced. 12 week onwards, consider the need for an acid pre-medication and RSI. Lower esophageal sphincter tone is reduced within the first few weeks of pregnancy, and intra-abdominal pressure rises in the second trimester. Surgery and anesthesia confers increased risk of miscarriage in the middle trimester and increased risk of early labor later in pregnancy. 20 weeks onwards, there is risk of aortocaval compression. 24 weeks onwards, the fetus is potentially viable, sometimes earlier. Considerations for the fetus. First trimester. Fetal organogenesis begins. Risk of teratogenesis in the first trimester when main organ systems are being developed, especially at 2 to 8 weeks. Causes of teratogenicity are diverse, including infection, pyrexia, hypoxia, acidosis, drugs, and radiation. Establishing whether drugs are teratogens can be difficult. As of yet, no definitive link between anesthetic agents and fetal teratogenesis has been found. Avoid maternal hypo or hyperthermia, hypoxemia, hypercarbia, and hypotension. Examples of teratogenic drugs include anti-epileptic drugs such as phenobarbital, valproate, carbamazepine, lamotrigine, phenytoin, and topiramate. Antibiotics such as chloramphenicol, tetracyclines, fluoroquinolones and azoles, warfarin, antithyroid drugs, vitamin A, diethylstilbestrol, anabolic androgenic steroids, thalidomide, and other drugs which can be referenced at UK Teratology Information Service and European Network of Teratology Information Services. During the second trimester, this is the preferred time for non-elective surgery. There is lowest risk for preterm delivery. Surgical exposure is enhanced as the uterus is lower in the abdomen. Major embryonic development is complete by the 8th week. In the third trimester, giving corticosteroids to facilitate fetal lung maturity should be discussed with the consulting obstetrician before surgery. NSAIDs should be avoided after 32 weeks due to concerns of premature closure of PDA. Drug safety for the fetus. Benzodiazepines. Case reports associating benzodiazepines with cleft lip has not been substantiated. Benzodiazepine exposure just before delivery may cause neonatal drowsiness and hypotonia. A single dose has never been associated with teratogenicity. Chronic administration of benzodiazepines may cause neonatal withdrawal symptoms post-delivery. Opioids and omeprazole are safe. Regarding induction agents, thiopental is safe. Propofol is safe to use during cesarean section at term. Propofol's use in early pregnancy has not been formally investigated, although it is not teratogenic in animal studies. Etomidate should be avoided as it reduces neonatal cortisol levels. It is not teratogenic in animal studies. Ketamine should be avoided in early pregnancy as it increases uterine pressure, which may lead to fetal asphyxia. Raised intrauterine pressure is not apparent in the third trimester. Inhalational agents. Halogenated inhalational agents have been used extensively in pregnancy and are safe. There is a theoretical concern of increased neuroapoptosis with these agents. However, a single relatively short exposure is unlikely to have negative effects. Inhalational agents may cause maternal hypotension at high concentrations, which may reduce uterine blood flow and lead to fetal distress. Inhalational anesthetics causes uterine relaxation, which may be beneficial. Epidemiological studies suggest that nitrous oxide is safe. However, it is sensible to avoid this agent due to its various side effects. Muscle relaxants are safe to use, as they are highly ionized and only very small quantities cross the placenta. Anticholinesterases are also safe as they are highly ionized and only minimal quantities cross the placenta. Chronic use of pyridostigmine to treat myasthenia gravis may cause premature labor. Regarding analgesics, opioids readily cross the placenta, but brief exposure is safe. Long-term exposure will cause symptoms of opioid withdrawal when the fetus is delivered. Animal studies suggest possible fetal teratogenicity if prolonged hypercapnia or impaired feeding develops as a side effect of opioid exposure. Chronic exposure to NSAIDs in early pregnancy may be associated with fetal loss. NSAIDs should be avoided after 32 weeks due to concern of premature closure of PDA and persistent pulmonary hypertension of the newborn. Single doses are unlikely to be harmful. Bupivacaine and lidocaine are safe. When used near delivery, bupivacaine has no significant neonatal neurobehavioral effects, while lidocaine may have a mild effect. Cocaine abuse during pregnancy increases fetal loss and may increase incidence of abnormalities of the genitourinary tract. Ondansetron should be avoided in the first trimester due to association with cleft lip formation. However, single doses are unlikely to increase the risk significantly. Fetal monitoring. Opinions differ regarding how and when fetal monitoring should be done. Decision to monitor fetal heart rate during surgery is specific to the patient and is based on institutional guidelines. The American College of Obstetricians and Gynecologists recommends fetal heart rate measurement using Doppler ultrasound before and after any given surgery regardless of gestational age, with the addition of contraction monitoring in a viable fetus. Most anesthetic agents crosses the placenta and may affect fetal heart rate tracing. It is not uncommon to see reduced variability after initiating anesthesia or analgesia. Fetal monitoring can alert the anesthetist if optimization of maternal positioning, oxygenation, or blood pressure is required. Maternal considerations. Maintain normal maternal physiological parameters throughout the perioperative period. Airway. Mucosal friability and edema occurs. Nasal intubation and instrumentation not recommended. There is risk of difficult intubation and mask ventilation. Difficult Airway Society has produced, in 2015, Algorithm for Obstetric General Anesthesia and Field Intubation. Respiratory. Reduced FRC leads to rapid desaturation during apnea due to reduced oxygen stores and increased VO2. Ensure ample time for pre-oxygenation prior to induction, and consider HFNC for apneic oxygenation. Increased VO2 leads to increased minute ventilation and physiological respi alkalosis. Titrate ventilator settings to EtCO2 of 27 to 32 mmHg. There is reduced chest wall compliance. A ramped or reverse Trendelenburg position may help optimize respiratory mechanics, especially in the maternally obese. CVS. Increased heart rate, blood volume, and stroke volume leads to increased cardiac output. This predisposes to heart failure in at-risk patients. Cardiac function may be assessed via functional status and echocardiography. Treat heart failure accordingly. Aortocaval compression leads to reduced venous return and reduced cardiac output. IVC compression can occur as early as 13 to 16 weeks gestation. Applying 15 degrees of left uterine displacement can prevent aortocaval compression by the gravid uterus. Published data are inconsistent as to when to initiate LUD. LUD beyond 18 weeks gestation has been recommended. Multiple gestation and obesity may require using LUD early in the pregnancy. Fetal bradycardia can be a sign of aortocaval compression. CNS. Reduced volume of epidural space due to epidural vein engorgement leads to high risk of spinal block in neuraxial anesthesia. There is increased sensitivity to opioids and sedatives. Increased volume of distribution leads to prolonged elimination half-life of many drugs. Adjust dosage and drug choices accordingly. Appropriate monitoring and treatment of complications of drugs, especially in at-risk population such as OSA. Light anesthesia is associated with increased catecholamine release and reduced placental blood flow. Renal changes includes increased GFR, which leads to increased renal drug clearance and reduce serum creatinine. Evaluate for kidney disease if serum creatinine is elevated. Increased renal blood flow leads to increased renal drug metabolism. Increased bicarb excretion counteracts physiological respi alkalosis but reduces the buffer capacity in acidosis. Gastric emptying and acid secretion do not change before labor regardless of BMI. Standard guidelines for fasting should be used before surgery. There is increased risk of regurgitation and aspiration as there is reduced lower esophageal sphincter tone with progesterone concentrations, cephalate displacement of the stomach by gravid uterus. However, there is no consensus for a specific gestational age at which tracheal intubation is required. Consider RSI with aspiration prophylaxis in any trimester in the presence of risk factors such as nausea, vomiting, pain, infection, GERD, history of hiatus hernia, and full stomach. Gallstones are more common in pregnancy. Assess for associated disease when indicated. Endocrine. There is increased insulin resistance in pregnancy. Maintain normal glycemia. Hematology. Pregnant patients are hypercoagulable from the first trimester. Consider VTE prophylaxis where appropriate. There is increased blood volume. Signs of blood loss may appear late. Physiological anemia and thrombocytopenia occurs. Leukocytosis with left shift occurs. Hence, inflammation may be masked. Type of anesthesia. Regional anesthesia with or without monitored anesthesia care. The combination of a mother maintaining her own airway together with minimal fetal drug exposure is desirable. Regional anesthesia can be safe during any trimester, depending on the individual's needs and medical history. Maintaining normal tension and avoiding hypoxia are critical for fetal and maternal well-being. Data demonstrating that regional anesthesia is safer than GA are lacking. The other option is general anesthesia, which can be safe during any trimester, depending on the individual's needs and medical history. Maintain normal tension and avoid hypoxia. The sedative effects of all anesthetics may be observed at lower doses than in non-pregnant patients, thus there is a reduced MAC requirement. Laparoscopy. This is considered safe during pregnancy. Laparoscopy has reduced morbidity compared with open procedures. CO2 insufflation and pneumoperitoneum may lead to increased risk of hypercarbia, hypotension, and hypoxemia, which may reduce utero-placental blood flow, DO2, and may lead to fetal distress. To reduce these risks, keep insufflation pressures between 12 and 15 mmHg and maintain maternal baseline PaCO2 and MAP. Reversal of neuromuscular block. Sugammadex. Sugammadex should be avoided in the first, second, and third trimesters due to its ability to encapsulate progesterone. Inadequate human studies and animal studies demonstrate potential of Sugammadex to affect the developing human brain. However, for cesarean delivery, Sugammadex is effective for reversal of neuromuscular block at the end of cesarean section with excellent maternal side effect profile. Pregnancy-associated increase in volume of distribution does not appear to affect the standard dosing of Sugammadex. Sugammadex transfer to breast milk is very low, hence it is safe in breastfeeding mothers. Situations where Sugammadex benefit outweigh risk includes CICV scenario and inadequate neuromuscular blockade reversal after cholinesterase inhibitors has reached a ceiling effect. Reversal with neostigmine and glycopyrrolate is safe. For the newly postpartum breastfeeding considerations, discarding breast milk while in PACU is not supported by ASA or Association of Anaesthetists. All anesthetic medications transfer to breast milk to some degree, but vast majority are in very low concentrations, which are considered safe for the newborn, except for opioids that have genetic variants for metabolism, such as codeine and pethidine, certain antibiotics such as tetracycline, and certain CVS drugs such as amiodarone and statins. Maternal considerations. Return to maternal physiological baseline is gradual and often takes place over weeks. Cardiac output may reach values 150% above pregnancy baseline immediately postpartum and may take up to 24 weeks to return to normal. Maternal heart rate stabilizes within 2 weeks. Physiological dilutional anemia seen during pregnancy resolves by 3 weeks postpartum. Gastric emptying, volume and pH returns to pre-pregnancy levels at 18 hours postpartum. Past year primary SAQs by Stewart in Ketamine Nightmares regarding CVS changes during pregnancy, respiratory changes during pregnancy, and mechanisms that facilitate oxygen and CO2 exchange in the placenta are included here for completion. These are my references. Thank you.